Good evening, and thank you for the invitation to talk about newborn compartment syndrome, a rare disease. I like to share our experience of the last 15 years with you. We treated 30 patients with this disease. What is newborn compartment syndrome? It's a perinatal ischemia of one extremity. Excuse me. At day of birth, they show this typical aspect. This reddish swollen hand and forearm is normally not recognized, also not in this girl. And by the pediatrician, it was assumed to be an infection caused by erysipelas. And they kept calm because hand and forearm went well, but after 3 months, she developed this Volkmann contracture. So the first signs of newborn compartment syndrome are these: red-blue colored skin lesions, a swollen hand and forearm, some with epidermolysis, a hanging arm, and always a unilateral appearance. But these skin changes are only the iceberg of the underlying disease. If fasciotomy is not performed, the muscle necrosis create contractures after 3 to 6 months. And also the nerves can be damaged by ischemia or by compression in the bottleneck area of the nerves. Later, the growth plates show a premature closure, leading to malposition. And also this may happen. This boy was born with a ulnar pseudarthrosis together with contractures and skin necrosis already at birth. Or this girl born with these huge circular skin defects, and after 4 months, she presents with these scar cuff around her forearm. To learn more about this disease, my colleagues, Max from my department and Ricarda Böttcher from Berlin, we used the World Congress to ask other colleagues via a survey to send their experience. And 18 participated, mostly they came from the United States and Germany. Let's go through some details of this survey. Males were more affected than females, and it's the same in the literature. Always one hand and forearm unilateral was involved. Only one exception is one leg affected and none with multiple extremities. The literature says the same. In our survey, the right side was more affected than the left side. In the literature, it's equally divided. Interesting is the parents' history. The age of the mother was uneventful, but the diabetes, 8 mothers of 50 had diabetes. This is 16%, and we found the same in the literature. So risk factors. Maternal diabetes seems to be a risk factor for that. Preterm born babies also. Birth weight not. We thought macrosomia would be a risk factor, but in our survey it wasn't. Twins were more often affected than in the normal population. In our 30 patients, preterm birth and maternal diabetes were the most often risk factors, but also we found some arterial thrombosis detected in 3 newborns and assumed in 6 newborns. Research at day of birth would be interesting to learn more about the reason of a vascular happening could cause this, but only 26 of 80 of the questionnaires mentioned a diagnostic at the first day of life. And if they made a Doppler or angiography, mostly it was pathologic. In blue is the Doppler, and in green, the pathologic ones. In the survey about the first signs, skin signs, blisters was the most often seen, followed by swelling, purple color, palsy, and skin necrosis, also same as we found. Let's talk about treatment. The best would be to recognize the compartment syndrome at day of birth by the neonatologist, and to have a surgeon who is courageous to open the hand and the forearm at day of birth, but often it's not recognized. In the questionnaires, in the 18 questionnaires, 23 mentions the therapy. In 17, fasciotomy was done. In 3, only on day of birth, and that only in these very severe cases. That is one of, we were lucky with this patient. This was the only one with the leg affected, and we performed a fasciotomy at day 2 of his life, and he healed without sequelae. But maybe that he is a little bit extraordinary, because the pressure was due to a loss of amnion in the last 2 months. So the pressure may have developed very slowly and not so immediately as in arterial thrombosis. About what the problem in treatment is, that normally the Newborn compartment syndrome is not recognized and no fasciotomy is done. The full amount of muscle damage appears with delay, and contractures worsen in growth. Initially, the forearm shortening is noticeable, and later severe skeletal deformities occur due to premature closure of growth plates. Let's go through the sequelae of this Newborn compartment syndrome. This is the girl I showed as first example. We resected all fibrotic flexor muscles and performed a neurolysis in her arm at age of 6 months, and received this open hand. We were lucky, but at age 3, she developed an extension contracture. At the beginning, the extensors seemed not to be involved, but they were. Also, the extensors were resected, and because of a free joint, passive joint motion, we performed a restoration of the finger flexors and extensors by free muscle transfer using 2 gracilis muscles. And the palmar gracilis was divided into 2 parts, one for the thumb and the other for the fingers, as Zucker recommended in 2011. Now I go through some examples. This boy was born with this dorsal skin defect, with this necrosis at the dorsal forearm. And after birth, it was thought to be a plexus palsy. The family visited 4 different colleagues, and they had different diagnoses for that. Plexus palsy was the first, Volkmann contracture the second, Rayleigh palsy the third, and cutis aplasia congenita the fourth. So not a consistent diagnosis, and not a sufficient treatment, because very shortly at age 2, the extension contracture recurred. And that is his arm at the age of 2.5, extension contracture, the wrist in 60-degree extension. And because of the resistance, we couldn't flex it, as you can see on the right photo. That is the intraoperative aspect, full of scar tissue at the dorsal aspect. We cut the extensor tendons, tenulized them, and fixed them temporarily to the periosteum, and used the next 2 months to improve passive wrist motion, to prepare the next step, the reconstruction of the extensors. That's he, 1 year post-op, no extension contracture and good prehension. But after 4 4 years, he showed the tendency to draw back into extension. And then we started with quengal orthosis to treat him conservatively. So growth deteriorates the situation. This boy you have already seen at the beginning, the ulnar suit arthrosis caused by the ischemia of the forearm, and that asked for stabilization, and we stabilized it with a vascularized free fibula transfer at the age of 3.5 years. Now, another example, a girl with a mild form of newborn compartment syndrome. She developed at the age of 9, she developed a premature closure of the growth plate with this deformity of the radius epiphysis. And in the NMR, you can see this cup-shaped defect of the epiphysis. Her forearm was shortened at age 9, 4 centimeters, age 13, 6 centimeters, with a good active range of motion and normal sensitivity. And we lengthened the forearm by 5.5 centimeters, and she was content with that. Next case, a boy from Croatia. That is his aspect 2 days after birth, with these necrosis at the distal radial forearm and at the proximal thumb ray. We saw him first at the age of 1 year. And in the operation, we resected all fibrotic muscles, that is, all deep flexors of thumb and fingers, and performed a neurolysis of the median nerve and restored the tendons in the same operation by tendon transfer. The prehension improved, but this severe adduction contracture of his thumb disturbed him and restricted his prehension. Therefore, the second operation was resection of all fibrotic interossei and performing a CMC arthrolysis and creating a first web by a parascapular flap. And later, he developed this premature closure of the growth plate. Now I show you the timetable of his X-rays. At the age of 1 year, already a broadening of the radius metaphysis is visible. It became clearer at the age of 3, and at the age of 8, it was a total closure of the radius epiphysis and a continuing growth of the ulna. At this time, we thought it would be he would benefit from operation to avoid deterioration in his further growth. So at age of 8 years, we lengthened the radius, preparing it with a distraction, and then very quickly we grafted the defect and plated it, and we performed epiphysiodesis of the ulna to avoid further difference in length of the both forearms. And this position maintained more or less 4 years later and 7 years later. Now he looks like this at the age of 15. I've seen him 3 weeks ago. The right forearm is shortened by 8 centimeters. He has a normal sensitivity, but a stiff CMC joint, no opposition. Finger extension is free, but flexion is reduced and powerless. Your judgment or our judgment, what we tried to gain was function, and no complication occurred. Now he has a sensate hand, which he can use as a helping hand for the other side. In comparison to a normal arm, it's a severe deformity and a shortened arm. Last case, it's a boy with very severe affectation. He had multiple arterial and venous thrombosis due to thrombophilia, with thrombosis of his arm, of his vena porta, and a cerebral infarction with epilepsy. At the age of 3 years, his contracture of the elbow was treated by release and covered by a pedicle latissimus dorsi flap in another hospital, efficient. And at 2 years later, they tried to improve the wrist contracture by pedicle grown flap, but that failed. We saw him first at age of 6 years with this arm, with a radial deviation of 50 degree, supination of 30 degree, all extrinsics at the forearm were fibrotic changed, and he has this severe malposition of his distal radius due to premature closure. But he has enormous sensitivity of his hand, and he has some intrinsic function. He could grasp this paper with a side-to-side pinch and good elbow function. For this reason, we tried to correct his wrist. We cut all scars at the radius side and creating this big defect of his soft tissue, and like a shark bite, and covered it with a free anterior lateral thigh flap, and prepared the next step with a wrist distraction. The next step was elongation of the radius by a graft, an open wedge osteotomy. That improved his wrist position, but after 2 years, he had partial recurrence. But the ALT, the flap, improved his soft tissues very well. 4 years later, he presented with a severe supination contracture of 120 degrees, which disturbed him immensely, because he couldn't use his right hand to help the other hand. Yes, we thought how we could help him to put the hand more in pronation out of the extreme supination. And learning from cases before, we thought that we had to perform 2 things: the release of the contracture and a bone correction. As a release of the supination was cutting all fibrotic tissue around the radial head and cutting of the membrana interossea. And the bone correction was callus distraction of the radius in a very special way using this hexapode system. The idea was to twist the radius around the ulna, as shown in this drawing, from the drawing in blue to the position in black. And that mirrors the X-rays. Yeah, I have to correct, yeah. That's he before this correction, and that's him 1 year post-op with a pronation, neutral pronation and active supination of 45 degree. We were astonished that he had an active supination. And that's he now, 23 years old, a very positive young man. And still he has this side-to-side grip, a good normal sensation of the hand and his elbow flexion. But he ended up with a lot of scars on his body, not only on the arm, but also on his abdomen, on his leg, and on his back. He allowed me to show these pictures. I asked him before if I can share it with you, and also on YouTube. So what have we learned from these 30 patients? The newborn compartment syndrome, the real one, that means that the ischemia happened around birth, in the 24 hours around birth. The damage can be reduced by early fasciotomy. The prerequisite for that is recognition by the neonatologist and a courageous hand surgeon for fasciotomy. If they develop a Volkmann contracture, it should be treated early by aggressive resection of fibrotic muscles around age of 6 months, and the nerves should be neuralized in the same operation. But sequelae can occur also later. The premature growth plate closure leads to malposition, which deteriorates with growth. Treatment of later contractures require reduction of tearing forces and bone correction. After huge soft tissue defects and contractures present at birth, the aim of treatment can only be to create an assisting hand. And a good soft tissue coverage is the best prerequisite for all later treatment, apart from release. Thanks for your attention.